Everybody experiences anxiety over the course of their lives. However, people who live with a diagnosed anxiety disorder are those for whom these feelings of anxiety are persistent and possibly lead to maladaptive behaviors in an attempt to reduce that anxiety. Today we'll be exploring some of the most common anxiety disorders. For some, discussing these diagnoses may be difficult. If you feel the need to pause the lesson and regroup, please do so, and then continue at your own pace. When the psychologically healthy feel anxiety, that anxiety they experience is clearly tied to a specific event or person. For example, we may be anxious about the specific test coming up tomorrow, or about graduation, or about meeting up with that friend you had a fight with 2 days ago. For people who live with a persistent sense of anxiety, which is not necessarily tied to any one specific event, their diagnosis is often Generalized Anxiety Disorder, or GAD. People with GAD feel anxious all the time. Often, this anxiety revolves around constantly seeing potential negative outcomes to even small-scale decisions or events. The problem with feeling such anxiety is that it destroys the mind's ability to focus, meaning that an individual is sometimes unable to deal with the everyday tasks of living. If even the act of making a decision leads to constantly considering bad outcomes, then an individual may hesitate to make any decisions at all, and thus feel impossibly stuck. Without treatment, this inability to act can lead to physical illness and even to secondary mental health diagnoses such as depression. Some individuals who have clinical anxiety have learned behaviors that mask or hide their anxiety when in social situations. They may seem like super organized people or super motivated high achievers, but in reality, their organization or their high achievement masks their anxiety about control or feelings of disapproval. Others living with GAD have adopted behavior that, from the outside, appears clingy, such as constantly seeking approval or reassurance, or conversely that seems detached, such as purposefully refusing an invitation because they're worried that nobody likes them and will think that they're boring. Persistent anxiety manifests physically as negative stress, which means it can lead to medical conditions like high blood pressure, brain fog, and digestive issues. These medical conditions may require pharmaceuticals for treatment and, as you can imagine, the stress of living with such conditions may, in turn, exacerbate a person's GAD. Thus, a GAD diagnosis often spirals into multiple diagnoses. Associated with GAD is panic disorder. People diagnosed with panic disorder regularly experience situations in which feelings of anxiety suddenly escalate into a panic attack because the individual is convinced that something horrible is about to happen in the immediate future. Symptoms of a panic attack include heart palpitations, shortness of breath that leads to choking sensations, trembling, and dizziness. Often, a person experiencing a panic attack is convinced that they're having a heart attack. As with regular anxiety, a person can experience a panic attack without having a clinical diagnosis of panic disorder. The diagnosis is dependent on how regularly the panic attacks are experienced. As with GAD, the regular experience of these physical symptoms may develop into medical diagnoses such as high blood pressure. Left untreated or not treated sufficiently well, high blood pressure can lead to a variety of other physical problems, including heart attacks and blindness. So again, individuals who live with panic disorder or GAD may have multiple diagnoses. Their Axis 1 diagnosis of the anxiety disorder, and then an Axis 3 diagnosis of an accompanying physical illness. Phobias are an anxiety disorder in which the anxiety is focused on a very specific event, activity, or situation. A phobia, an intense and irrational fear, is not the same as disliking or hating something. The fear associated with a phobia is like believing that because of that specific object, activity, or situation, they might die. When faced with their phobia, especially when it happens unexpectedly, phobic individuals often experience either the fight, flight, or freeze reaction and, in severe cases, a panic attack. But again, phobia is not dislike. For example, many people hate cockroaches with a passion, And it's understandable, right? They're gross, and they can be disease vectors, and they have survived since before the dinosaurs, largely unchanged. It's like they don't really evolve. And should we trust things that don't really evolve? People will go to great lengths to avoid cockroaches. For instance, if there's one in a room, a person might give it a very wide berth or jump onto a table or chair until it passes. But despite all that dislike of cockroaches, most people don't fear that they're going to die because cockroaches are around. Thus, most people don't have a phobia of cockroaches, they just hate them. Humans being humans, there are common fears, some of them probably clearly linked to our evolution, which persist across populations around the world. These top fears are presented on screen. Notice how many of them are associated with animals, probably because, at some point in our distant past, humans were prey, not hunters. Notice also things like fear of storms, fear of small spaces, and conversely, fear of heights. All of these probably connect in some way to our evolutionary past. Among consistent findings about general fears and phobias are that humans as a population generally fear being stranded on the ocean more than being stranded in a desert. It's about 62 to 24%. And in the United States, we fear the IRS more than God. It's about 57 to 30%. On a more sobering note, researchers also find that even in Western countries where phobias are more commonly accepted and treated, it is quite rare that a person with a potential phobia diagnosis seeks professional help to deal with their fear. Conversely, one of the most accepted and commonly known anxiety disorders is Obsessive-Compulsive Disorder, or OCD. OCD is characterized by having persistent, unwanted thoughts, obsessions, which then drive a person to specific and often repetitive actions or compulsions. Many people experience what might be considered mild forms of OCD, usually exhibited as specific actions. For instance, we'll admit that we're, quote, OCD about the way our desk or room is organized, and so we color code our notes or our calendars, but really, this isn't OCD. People diagnosed with OCD experience their disorder as something closer to a phobia or GAD. For people living with OCD, their mind cannot relax until the obsession and the compulsion are completed to the individual's satisfaction. Many obsessions and compulsions are tied to a deathly fear, such as a fear of illness that leads to such continual hand washing that a person scrubs their skin raw, or a fear of dirt and germs that leads to such regular cleaning that hours of each day are spent tidying up even already tidy spaces. A formal diagnosis of OCD means that a person's life is limited because so much of their time is spent attempting to quiet their obsessive thoughts through their compulsive actions. Their obsessive thoughts and accompanying compulsive actions may be so overwhelming that they don't or can't leave home. And, as with GAD, OCD may also be accompanied by a secondary diagnosis, such as depression. An important reason that obsessions generate so much anxiety and such compulsions is that people living with OCD feel like they cannot know anything related to their obsession with any certainty. They may start to doubt their own senses. Their doubt may lead them to believe that they are taking unbearable risks if they don't perform their compulsive rituals. For example, they may see that their hands look clean, but they need to wash them anyway, and may do so 10, 20, or more times. And yet, in other areas of their lives, those areas not directly connected to their obsessive thoughts, people living with OCD may use the normal process of reasoning and may even be able to recognize that their obsessions and/or compulsions are not logical. While OCD is most commonly found and diagnosed in late adolescence or early adulthood, it can affect small children. OCD also does tend to run in families, which initially led some researchers to conclude that OCD may be a learned behavior. However, these same researchers found that, generation after generation, OCD obsessions and compulsions take different forms. For instance, where a mother who has OCD may be a checker, someone who has to check and recheck that the window is closed, the door is locked, her pants are buttoned, etc., her son may be a washer, someone who has to wash their hands 10 times because that's the compulsive behavior that quiets their obsessive thoughts. Post-traumatic stress disorder, or PTSD, is, like OCD, closely linked to a specific experience, this one of trauma. And research has shown that the more emotionally traumatic the experience is for an individual, the higher the risk for developing PTSD. This diagnosis was initially reserved for war veterans, but in the last few decades, the diagnosis has broadened to include people who have experienced war, such as civilians, people who have experienced abusive situations, people who have experienced sudden and unexpected losses, and people who have witnessed shocking or upsetting events. There is currently much debate about the diagnosis of PTSD because some people who have experienced great trauma seem to have no or very few post-traumatic symptoms, and what symptoms they do have diminish over time even without professional help. At the same time, there are people who experience what many might consider a regular or normal life event, for instance, the death of a parent or the end of a friendship, and who begin exhibiting the symptoms of PTSD. Since PTSD is so closely tied to emotional upheaval, its development as a disorder is itself tailored to the individual experiencing the trauma. A person living with PTSD may experience flashbacks or suddenly find themselves in a situation that is superficially similar to their traumatic experience, and their physiological response is a panic attack. PTSD can also manifest itself similarly to GAD, meaning that a person feels so constantly on edge that they have heightened emotional reactions to otherwise quote-unquote normal situations. A mild joke may lead to uncontrollable laughter, or a small disagreement may lead to feelings of rejection or extreme sadness. PTSD also often manifests itself as nightmares, which include the literal reliving of the traumatic experience night after night. As with GAD, the long-term effects of PTSD include high blood pressure and all its possible long-term effects, including digestive issues. For some people, a PTSD diagnosis is accompanied with a medical diagnosis, a traumatic brain injury, or perhaps broken bones, or a wound that required surgery and then physical therapy and recovery. As is also true with other anxiety disorders, someone with PTSD may also be diagnosed with a secondary disorder, such as depression. So, why do some humans develop such sustained anxiety that it leads to a clinical diagnosis? Researchers believe that there are two basic theories which explain anxiety disorders: the learning perspective and the biological perspective. The learning perspective holds that fear, the root of anxiety, is learned, either through conditioning or through observational learning. This view connects back to the concept of learned helplessness. Some psychologists believe that individuals may retain a conditioned fear even after having forgotten the specific circumstance that created it. Further, they believe that, over time, the initial experience of fear can grow into a longer list as an individual generalizes their original fear and is faced with more events that they feel they couldn't predict or control. If anxiety is learned, then the therapy for anxiety could focus on unlearning the behavior. The biological perspective holds that anxiety may be due to evolutionary processes. For instance, a snake phobia makes sense because many snakes are venomous or otherwise pose a survival risk to humans. Alternatively, anxiety may be due to individual differences in brain chemistry or genetics. If anxiety is due to brain chemistry, then therapy for anxiety would rest with pharmaceuticals. If it's the result of genetics, then it's possible that some future genetic therapy could develop and treat anxiety. So, it's possible that the reasons why anxiety disorders manifest themselves in the human population goes back to the old nature versus nurture debate. Is it nature, human biology, that results in a predisposition toward anxiety? Or is it nurture, human learning, that feeds anxiety? Or, as we've already seen throughout the course, is it most likely a mixture of both?